Story 1. The Vanishing Bed Space. I stood in the center of the ICU at 2:47 a.m. staring at the floor map on my tablet. Bed 14 was gone. Not empty. Gone. The entire bed space had vanished from the layout, the numbered sequence jumping from 13 to 15 as if 14 had never existed. I blinked, refreshed the screen, and it reappeared. The patient name loaded slowly. Garrett Milhouse, admitted 11/18/2019. I felt my throat tighten. I had pronounced Garrett dead in 2019. I had held his daughter's hand while she signed the paperwork, and now his name was back on my assignment sheet, vitals updating in real time. I have been a float charge nurse for 11 years. I have worked every unit in this hospital, covered every shift configuration, managed every kind of crisis. I know how to read a floor map, how to track bed assignments, how to coordinate staffing across 3 ICUs simultaneously. My job is built on pattern recognition, spatial memory, and the ability to anticipate problems before they manifest. I do not get confused about bed numbers. I do not lose track of patient locations. That is why what happened during my overnight rotation in November still unsettles me in ways I cannot adequately explain to my colleagues. The shift began routinely. I clocked in at 7 p.m., received handoff from the outgoing charge nurse, and reviewed the assignment board for all 24 ICU beds. The census was typical for a Tuesday. 18 occupied beds, 6 empty and cleaned for potential admissions. I distributed the patient assignments among the nursing staff, confirmed that respiratory therapy had completed their evening rounds, and settled into the charge desk with my tablet to monitor the electronic documentation system. The ICU was quiet in the way that experienced nurses know is temporary. I used the lull to review the upcoming schedule, checking for any call-outs or coverage gaps. At approximately 10:15 p.m., I performed my first walking rounds. I visited each occupied bed space, checked in with the bedside nurses, and visually confirmed that the patients matched the names on my census. Everything aligned perfectly. Bed 1 through bed 24, with the expected gaps where rooms remained unoccupied. I returned to the charge desk and documented my rounds in the logbook, noting no significant concerns. The night felt manageable. The first anomaly occurred at 1:33 a.m. I was reviewing lab results on my tablet when I noticed the floor map interface flickering slightly. The digital layout of the ICU, which normally displayed as a static grid with color-coded bed assignments, seemed to refresh itself without my input. I assumed it was a software update running in the background. Our hospital's electronic system frequently performed automatic maintenance during overnight hours. I closed the app and reopened it. The map loaded normally. 18 occupied beds in their correct positions. 30 minutes later, during my second walking rounds, I experienced a moment of disorientation in the central corridor. I have walked this ICU layout hundreds of times. I know the exact number of steps between the charge desk and each bedside, the precise location of every supply closet and medication room. But as I approached the even-numbered side of the unit, the hallway felt subtly different. The distance between bed 12 and bed 16 seemed longer than I remembered. I stopped, counted the doorways, and confirmed the sequence. 10, 12, 14, 16, all present. I attributed the sensation to fatigue and continued my rounds. At 2:47 a.m., I returned to the charge desk and opened the floor map on my tablet to assign an incoming admission. That was when I saw it clearly. Bed 14 was missing from the layout. The digital grid showed beds numbered in sequence, 10, 12, 13, 15, 16, but where bed 14 should have been, there was empty space, as though that section of the unit simply did not exist in the system. I stared at the screen, trying to rationalize what I was seeing. I refreshed the app. The bed reappeared, and with it, a patient name I had not seen in over 5 years. Garrett Milhouse. I felt a cold sensation spread through my chest. Garrett had been one of my patients during my time as a bedside nurse in this same ICU. He had been admitted with septic shock following a routine surgical procedure. Despite our interventions, his condition deteriorated rapidly. I remembered his daughter, a woman in her early 30s who sat beside his bed for 72 hours, refusing to leave even to eat. I remembered the exact moment his heart stopped, the way the monitor alarm sounded, the weight of pronouncing his time of death. Garrett Milhouse died on November 18, 2019. I had documented his death myself, yet his name now appeared on my census, listed as currently admitted to bed 14, with vitals updating in real time, heart rate 78, oxygen saturation 95%, blood pressure 118/72. I touched the entry to view his chart. The admission timestamp read 11/18/2019, 14:32. The attending physician was Dr. Voss, who had retired 3 years ago. The primary nurse assigned was listed as me, under my employee ID from 2019. I stood and walked directly to bed 14. The door was closed, which was unusual but not unprecedented for isolation cases. I pushed it open. The room was dark, unoccupied, and smelled faintly of disinfectant. The bed was stripped, the mattress bare, the monitors powered off. I checked the room number on the wall, 14. I returned to my tablet. Garrett's name had disappeared. Bed 14 now showed as empty and available. I told myself it was a database error, some kind of archival glitch that had temporarily pulled old patient records into the active system. It happens occasionally with electronic medical records, particularly after system updates. I documented the incident in my shift notes and moved on. But 20 minutes later, it happened again. This time, bed 8 vanished from the floor map. When it reappeared, the patient name was Colleen Brandt. I recognized her immediately. Colleen had been a long-term ICU patient, a woman in her 60s with end-stage liver failure. She had remained in the unit for weeks while awaiting a transplant that never came. I had cared for her during multiple shifts, had grown familiar with her husband's daily visits, his quiet grief. Colleen had died in early 2020. I had been present when the family decided to withdraw life support. I had turned off her ventilator myself. Now her vitals were displayed on my screen, her oxygen saturation slowly declining in real time. I walked to bed 8. The room was empty. When I returned to the charge desk, her name was gone. Over the next 2 hours, 5 more beds disappeared and reappeared with the names of patients I had cared for, all deceased. Each time I walked to the bedside and found nothing. Each time the vitals displayed on my tablet matched the patterns I remembered from their final hours. Garrett's gradual bradycardia, Colleen's desaturating oxygen levels, Franklin's blood pressure dropping despite maximal vasopressor support. At 4:50 a.m., I began to notice a more disturbing pattern. The beds were not reappearing in random order. They were following the sequence of my own shift rotations from years prior. Garrett had been my first ICU death as a bedside nurse. Colleen had been my second. Franklin, my third. The ICU was replaying my professional history, Chuang Kong Jian by bed space, loss by loss. I tried to talk to one of the bedside nurses, a newer graduate named Tim who was working bed 6. I asked him if he had noticed anything unusual about the floor map. He looked at me strangely and said the map had been stable all night. I showed him my tablet. He saw 18 occupied beds, 6 empty, all correctly labeled. No missing bed spaces, no deceased patient names. I realized the phenomenon was isolated to my view, my device, my perception. At 5:30 a.m., I walked my final rounds before shift change. As I moved through the unit, I counted the doorways again, 10, 12, 14, 16. But when I reached what should have been bed 14, I experienced a moment of profound spatial confusion. The doorway was there, the room number was there, but the interior seemed somehow flattened, as though I were looking at a photograph rather than a three-dimensional space. I stepped inside. The room was empty, but the air felt different, warmer, denser, as though recently occupied. I returned to the charge desk and checked the system one final time before handoff. The floor map was stable, all beds accounted for. But in the lower corner of the screen, I noticed a small notation I had never seen before. Assignment history. 47 rotations, 94 patient interactions, 14 documented losses. I touched the notation. It expanded into a list of names, all patients I had cared for who had died under my watch. Garrett, Colleen, Franklin, and 11 others. The system logged me out automatically at 6:58 a.m. I gathered my belongings and gave report to the incoming charge nurse, mentioning nothing about the vanishing bed spaces. What would I have said? That the ICU was cataloging my failures? That the floor map was reorganizing itself around my grief? I have worked 4 more shifts since that night. Each time during the early morning hours, beds disappear and reappear with names I recognize. The list grows longer. Last week I saw a name I did not recognize. Angela Faust, admitted 12/03/2025. I do not know who Angela is. I have never cared for anyone by that name. But her vitals are displayed on my tablet now, updating in real time, waiting for me to find her bedside. I wonder if the ICU is showing me the past or preparing me for something I have not yet experienced. I wonder if every loss I have witnessed is being archived somewhere in the system, indexed and retrievable, waiting to resurface when the conditions align. I wonder if the layout I am navigating is the same one my colleagues see, or if I have been walking a version of the unit that exists only in my memory, growing more detailed with each shift, pulling me deeper into a map I can no longer trust. Some nights I still count the doorways. 10, 12, 14, 16, all present, all accounted for. But the distance between them keeps changing, and I am no longer certain whether the beds are vanishing, or I am simply beginning to see the spaces that were always there, waiting to be filled. Story 2, The Silent Ventilator. I found it during the 3 a.m. circuit check. Ventilator Unit 14B running in Room 9, a storage space that hadn't housed a patient in 8 months. The display showed perfect tidal volumes, normal pressure curves, oxygen saturation holding at 97%. The tubing was warm, the humidifier chamber was half full. The bellows rose and fell with the mechanical precision of a functioning lung. But there was no patient. The bed was empty, stripped down to the bare mattress. I reached for the power switch and the ventilator alarm shrieked once, a sound I'd never heard from that model before falling silent. When I checked the maintenance log, I found my own signature on a service report dated April 2018. I didn't work here in 2018. I have been a respiratory therapist for 14 years, the last 6 spent in critical care. My work is technical, procedural, and rooted in measurable outcomes. I manage ventilators, troubleshoot mechanical failures, adjust flow rates and PEEP settings based on arterial blood gas results. I am trained to trust the equipment, to interpret the data it provides, and to intervene when that data indicates a problem. The machines I work with are not mysterious. They are assemblies of sensors, valves, and microprocessors designed to perform specific functions. They do not operate independently. They do not sustain invisible patients. That is why what I experienced over a series of night shifts in late November has fundamentally altered my understanding of the systems I rely on. The first incident occurred on a Tuesday night. I was assigned to the ICU, covering 12 ventilated patients across 2 units. My responsibilities included performing circuit checks every 4 hours, responding to ventilator alarms, and adjusting settings as ordered by the physicians. The census was moderate, the patients stable. I began my rounds at 11 p.m., starting with the medical ICU and working my way through the surgical side. At approximately 3:10 a.m., I was walking the central corridor of the surgical ICU when I heard a faint alarm. It was not the sharp, insistent tone of a critical alert, but a softer, rhythmic beeping that indicated a routine notification, something like a low-pressure warning or a filter change reminder. I followed the sound to room 9, a single-occupancy space at the end of the hallway. According to my census sheet, room 9 was unoccupied. It had been closed for maintenance 2 months prior due to a malfunctioning nurse call system, and it was not scheduled to reopen until the following week. The door was slightly ajar. I pushed it open and saw ventilator unit 14B positioned beside the empty bed, powered on and running. The display screen showed active ventilation, tidal volume 480 ml, respiratory rate 14 breaths per minute, FiO2 40%, PEEP 5 cm H2O. The pressure volume loop traced a perfect curve on the monitor. The ventilator tubing extended from the machine to where a patient's airway would normally be, but it terminated in open air, connected to nothing. Yet the tubing was warm to the touch and condensation had formed inside the corrugated plastic, exactly as it would if it were delivering heated, humidified air to living tissue. I checked the ventilator's alarm log. The low-pressure alert had triggered 30 seconds earlier, likely because the circuit was open to atmosphere rather than sealed against airway resistance. I pressed the alarm silence button and examined the machine more carefully. The humidifier chamber was half full of sterile water, still warm. The bacterial filter at the patient connection point was clean but appeared used, its surface slightly discolored in the way that indicates hours of airflow exposure. I assumed a staff member had been testing the equipment and had forgotten to power it down. It was sloppy, but not unprecedented. I reached for the main power switch. The moment my fingers touched the button, the ventilator emitted a sound I had never heard from that model. A sharp, ascending shriek that lasted approximately 2 seconds before cutting off abruptly. The display screen flickered, and for a brief moment I saw a waveform I did not recognize. An irregular, chaotic pattern that looked nothing like normal respiratory mechanics. Then the screen went dark. I powered the ventilator back on to check for errors. It booted normally, running its standard diagnostic sequence. All systems reported functional. I disconnected the circuit, coiled the tubing, and wheeled the machine back to the equipment storage room. I documented the incident in the maintenance log as Unit 14B found running unattended in Room 9, powered down and returned to storage, no apparent malfunction. I noted the time as 3:22 a.m. and signed my initials. The following night, I was assigned to the same ICU. During my 3 a.m. rounds, I passed room 9 and noticed the door was open again. I looked inside. Ventilator unit 14B was back, positioned in the exact same spot beside the empty bed, running with the same settings I had seen the night before. The display showed identical parameters. Tidal volume 480 ml, rate 14, FiO2 40%. The tubing was warm, the humidifier was half full. I checked the equipment log on my phone. Unit 14B was listed as being in storage, last documented movement at 3:22 a.m. the previous night, by me. I walked to the storage room. The ventilator was not there. I returned to room 9 and examined the machine more closely. I checked the serial number on the back panel, VT14B00739. I cross-referenced it with the hospital's asset database. The serial number matched Unit 14B, but the service history showed something that made me pause. The most recent maintenance entry was dated April 14, 2018. The technician's signature read, J. Calloway, RT. That is my name. Those are my initials. But I did not begin working at this hospital until September 2019. I have no memory of servicing this ventilator, no record of employment here in 2018, no explanation for how my signature appeared on a document created 16 months before I was hired. I took a photograph of the maintenance screen with my phone. I powered down the ventilator again, this time waiting to see if it would emit the same alarm. It shut off silently. I wheeled it back to storage and locked the equipment room door behind me. On the third night, I arrived for my shift and immediately checked the storage room. Unit 14B was missing. I went directly to room 9. The ventilator was there running with the same settings, but this time the display showed additional data I had not seen before. Patient ID number, admission date, and initials. The ID number was alphanumeric, following the hospital's standard format. The admission date was listed as November 28, 2025, 2 days prior. The initials were JC. I opened the electronic medical record system on the mobile workstation and searched for the patient ID. No results. I searched by initials and admission date. No matches. I returned to the ventilator and checked the internal event log, a feature that records every alarm, setting change, and user interaction. The log showed continuous operation for the past 72 hours. It listed multiple user interactions, adjustments to FiO2, modifications to tidal volume, responses to alarms, all time-stamped and attributed to user ID JC2847. That is my employee ID. According to the ventilator's log, I had been managing this patient for 3 consecutive nights, making clinical decisions, responding to desaturation events, titrating oxygen levels. But I had no memory of these interactions. I had not touched the ventilator except to power it down and move it to storage. I sat in the chair beside the empty bed and watched the ventilator run. The bellows rose and fell with rhythmic precision. The pressure gauge fluctuated gently with each mechanical breath. The capnography waveform traced the exhalation of carbon dioxide that should not have been there, should not have been measurable because there was no patient, no airway, no source of expired gas. Yet the sensor detected it, quantified it, displayed it as a numerical value, ETCO238 mmHg. I reached out and placed my hand near the end of the ventilator tubing where it hung open in the air. I felt a faint warmth, a barely perceptible flow of gas moving past my palm. I closed my eyes and tried to sense any physical presence in the room, any indication that something or someone was occupying the space where a patient should have been. I felt nothing. But when I opened my eyes, the oxygen saturation reading on the ventilator had dropped to 89%. I adjusted the FiO2 from 40% to 50%, following the same protocol I would use for a desaturating patient. The saturation improved over the next 30 seconds, climbing back to 95%. The ventilator logged the change, attributed it to my user ID, and time-stamped it at 3:47 a.m. I spent the next hour performing tests. I disconnected the circuit entirely and ran the ventilator in open air. The pressure alarms triggered immediately as expected, but the oxygen saturation reading persisted, fluctuating between 92% and 96% as though still measuring a patient's arterial blood oxygen level through a sensor that was no longer connected to anything. I reconnected the circuit. The alarms silenced. The ventilator resumed normal operation. I tried powering the unit off by unplugging it from the wall. The display went dark for approximately 3 seconds, then rebooted on battery backup. I had not known that model was equipped with a battery. I checked the technical manual on my phone. It was not. At 5:30 a.m., I left room 9 and went to find the night supervisor. I intended to report the malfunctioning equipment and request that Unit 14B be taken out of service for a full diagnostic evaluation. But when I reached the supervisor's office, I found myself unable to articulate what I had experienced. How could I explain that a ventilator was sustaining a patient who did not exist? That it was logging my interactions with a person I had never met? That my signature appeared on service records predating my employment? I returned to room 9. The ventilator was still running. I sat down and opened the internal event log again, scrolling back through the entries. The log extended much further than 72 hours. It showed continuous operation for months, with user interactions attributed to multiple different employee IDs, some of which I recognized as former staff members who had left the hospital years ago. The earliest entry was dated April 14, 2018, the same date as the maintenance signature bearing my name. I clicked on that entry. It was a routine circuit change, documented as standard procedure. The notes section included a single line of text. Patient stable, responding to ventilatory support. Prognosis uncertain. Continue current settings until further assessment. I searched the hospital archives for any patient admitted to room 9 in April 2018. I found one. A 62-year-old male admitted with respiratory failure secondary to pneumonia. The patient had been intubated and mechanically ventilated for 6 days before being successfully extubated and transferred to a step-down unit. The attending physician was Dr. Hennings, who still works in the ICU. The primary respiratory therapist assigned to the case was listed as J. Calloway. I contacted Dr. Hennings the following morning and asked if he remembered the case. He did not. I described the patient's diagnosis and the timeline. He checked his own records and confirmed that he had been the attending physician, but he had no specific recollection of the individual. I asked if there was anything unusual about the case, any complications or unexpected outcomes. He said no. It had been a routine recovery. I did not tell him about the ventilator. I have worked 5 more shifts since then. Each night I check room 9. The ventilator is always there, always running, always displaying the same initials, JC. The settings change slightly from night to night, as though someone is titrating therapy based on evolving clinical needs. The oxygen saturation fluctuates. The tidal volumes adjust. The PEEP increases incrementally. Last night I checked the patient ID number again. It had changed. The new ID corresponds to a patient currently admitted to the medical ICU, a woman in her 70s with ARDS. She is on a different ventilator in a different room under the care of a different respiratory therapist. But when I checked Unit 14B, it was displaying her exact ventilator settings, mirroring her therapy in real time. When her nurse increased her PEEP in room 22, the same adjustment appeared on Unit 14B in room 9 30 seconds later. I do not know if the ventilator is documenting reality or creating it. I do not know if I serviced this machine in 2018 or if my role in its operation is being retroactively inscribed into records I cannot access. I do not know who or what the machine believes it is sustaining. But I know that when I stand beside it and place my hand near the tubing, I can feel something, not air, not warmth, but a presence. A faint pull, as though the ventilator is not pushing breath into a patient, but drawing something out of the space where a patient should be. And I know that my signature will appear on the next maintenance log, dated sometime in the future, documenting a service I have not yet performed on a machine that should not still be running. Some equipment, I am learning, does not stop when you tell it to. Some systems sustain processes that extend beyond the patients we can see. Story 3. The shifted dosing sheet. I was reconciling the morning medication orders when I noticed the timestamp, 6:42 a.m. It was currently 6:18 a.m. The dosing sheet had been printed 24 minutes into the future. The medication was propofol, 50 mg IV push, ordered for a patient in bed 11, except bed 11 was empty and had been for 3 days. The prescribing physician was Dr. Rains, who had called in sick that morning, and at the bottom of the sheet in the pharmacist verification field was my signature, precise, unmistakable, already approving a dose I had never reviewed. I looked at the clock again. 6:19 a.m. The sheet in my hand should not exist yet. I have been an ICU pharmacist for 9 years. My role is to review medication orders for appropriateness, verify dosing calculations based on patient weight and renal function, ensure there are no dangerous drug interactions, and prepare high-alert medications for administration by nursing staff. I work with precision. I double-check every calculation. I compare every order against evidence-based protocols. Medication errors in the ICU can be fatal within minutes, and I have built my career on preventing those errors. I trust my training, my protocols, and my attention to detail. That is why the events that began 3 weeks ago have undermined my confidence in ways I am still struggling to reconcile. It started on a Monday morning. I arrived at 6 a.m. to begin my shift, relieving the overnight pharmacist. The ICU was quiet. Census was 14 patients, all stable. I settled into the satellite pharmacy workspace, a small room adjacent to the main ICU floor, and began reviewing the pending medication orders that had accumulated overnight. The process was routine. I opened the electronic prescribing system, sorted the orders by priority, and started working through the queue. The third order in the list was for propofol, a sedative commonly used in the ICU for mechanically ventilated patients. The order was for bed 11, dosed at 50 milliliters IV push. I immediately flagged it as unusual. Propofol is typically administered as a continuous infusion, not as a bolus injection. A 50 milliliter push dose would be appropriate for procedural sedation, but bed 11 was listed as empty in the census. I checked the patient name associated with the order, Douglas Tennyson. I did not recognize the name. I opened his chart. Douglas Tennyson was a 74-year-old male with a history of chronic obstructive pulmonary disease. According to his record, he had been admitted to the ICU 6 days earlier with respiratory failure and had been intubated and sedated. The medication order I was reviewing was dated and time-stamped at 6:42 a.m. November 18, 2025. I glanced at the clock on my computer screen. It was 6:18 a.m. I assumed the timestamp was an error, a glitch in the electronic system. It happens occasionally. Clocks drift. Servers desynchronize. I scrolled through the order details. The prescribing physician was listed as Dr. Rains, one of the ICU intensivists. Everything appeared legitimate except for the impossible timestamp. I picked up the phone to call Dr. Rains to verify the order. The nurse coordinator answered and informed me that Dr. Rains had called in sick that morning and was not in the hospital. I hung up and returned to the order. I refreshed the screen. The timestamp had not changed. 6:42 a.m., but now I noticed something else. At the bottom of the order, in the pharmacist verification section, was my digital signature. The field showed that I had reviewed and approved the medication at 6:41 a.m., 23 minutes from now. I had not approved the order. I had not even finished reviewing it. Yet the system indicated that I had already verified it, signed off on it, and cleared it for administration. I checked my user activity log. It showed that I had logged into the system at 6:02 a.m. and had been actively reviewing orders since 6:05 a.m., which was accurate. But it also showed a verification action for Douglas Tennyson's propofol order at 6:41 a.m., an action I had not performed. I printed the order, intending to show it to my supervisor. The printout included the same future timestamp, the same pre-signed verification. I walked to bed 11. The room was empty, the bed stripped, the monitors off. I checked the census board in the hallway. Bed 11 was listed as unoccupied, available for admission. I returned to the pharmacy and called the ICU unit clerk. I asked if there had been a recent discharge from bed 11. She confirmed that the bed had been empty since the previous Friday. I asked if there was a patient named Douglas Tennyson currently in the ICU. She checked the system. No patient by that name. I filed the printout in my desk and made a note to report the system error to IT. But I could not shake the feeling that the order was not an error. It was too detailed, too specific. The dosing was precise, the indication appropriate for procedural sedation, the timing consistent with a morning intubation or line placement. It felt like a real order that had somehow been displaced in time. At 6:42 a.m., I was reviewing a different patient's antibiotic regimen when my computer emitted a soft chime. A new notification appeared. Medication order verified and approved for Douglas Tennyson, bed 11, propofol 50 mg IV push. I clicked on the notification. It opened the same order I had reviewed 24 minutes earlier. The timestamp now matched the current time. My signature was still present in the verification field. I stood and walked back to bed 11. The room was no longer empty. A patient was in the bed, intubated, sedated, connected to a ventilator and multiple IV infusions. The bedside monitor displayed vital signs. Heart rate 82, blood pressure 128/76, oxygen saturation 98%. I checked the patient identification band on his wrist. Douglas Tennyson. I asked the nurse at the bedside when the patient had been admitted. She looked at me strangely and said he had been there since the previous Tuesday, 6 days ago, exactly as his chart indicated. I asked if she had just administered propofol. She confirmed that she had given a 50 mg bolus 2 minutes earlier at 6:40 a.m. per my verified order, in preparation for a central line placement scheduled for 7 a.m. I returned to the pharmacy in a state of confusion I could not rationalize. I checked the census system again. Douglas Tennyson was now listed in bed 11, admitted 6 days prior. I opened his full medical record. It was extensive, detailed, documenting his entire ICU course, daily progress notes, nursing assessments, lab results, imaging studies. I searched for any indication that he had been admitted that morning. There was none. According to every record in the system, Douglas Tennyson had been a continuous presence in bed 11 for the past 6 days. But I had walked to that room at 6:20 a.m. and it had been empty. I told myself I had been mistaken, that I had looked into the wrong room, that my fatigue had caused a momentary lapse in attention. But I could not convince myself. I had checked the room number on the door. I had confirmed it against the census board. Bed 11 had been unoccupied. 2 days later, it happened again. I was reviewing morning orders when I encountered a medication I immediately recognized as problematic, vancomycin, dosed at 2 grams IV for a patient in bed 7. The dose was too high. Vancomycin is renally cleared and dosing must be adjusted based on kidney function. I opened the patient's chart. Her name was Marcia Voss, a 68-year-old female with sepsis. Her creatinine level was elevated at 2.1 mmol/dl, indicating impaired renal function. A 2-gram dose would be excessive, potentially toxic. I checked the timestamp on the order, 7:15 a.m. The current time was 6:52 a.m. The order was dated 23 minutes in the future, and it was already verified, signed with my digital signature at 7:14 a.m. I called Dr. Lindgren, the prescribing physician. I explained that the vancomycin dose needed to be adjusted based on the patient's renal function. He paused, then told me he had already modified the order per my recommendation an hour earlier. He said I had called him at 6:30 a.m. to discuss the dose, and he had reduced it to 1 gram. I had not called him at 6:30 a.m. I had not even seen the order until 6:52 a.m. But when I checked the order again, it had changed. The dose now read 1 gram, appropriately adjusted. The timestamp was 6:35 a.m. My verification signature was present, dated 6:50 a.m. I checked my phone log. It showed an outgoing call to Dr. Lindgren at 6:30 a.m., duration 4 minutes. I have no memory of that call. Over the next 2 weeks, the pattern repeated with increasing frequency. I would encounter medication orders time-stamped in the future, already bearing my verification signature. When the future timestamp arrived, the orders would become active and the patients they referenced would materialize in beds I had previously confirmed were empty. My colleagues reported no irregularities. The nursing staff confirmed receiving medications I had no recollection of preparing. The physicians verified phone conversations I could not remember having. I began documenting every order I reviewed, photographing the timestamps, recording my actions in a personal log separate from the hospital system. I wanted proof that I was not experiencing some form of cognitive lapse, that the discrepancies were real. But each time I returned to review my documentation, the timestamps had aligned. The photographs on my phone showed current times, not future ones. My handwritten notes described routine verifications, not temporal anomalies. Last week I encountered an order that clarified the nature of what was happening. It was for potassium chloride 40 mqv push, ordered for a patient in bed 3. The dose was lethal. Potassium must be diluted and infused slowly. A concentrated bolus would cause immediate cardiac arrest. It was exactly the kind of error I was trained to catch, the kind of mistake that should never reach a patient. The timestamp was 8:20 a.m. The current time was 7:55 a.m. The order was already verified with my signature dated 8:19 a.m. I checked the patient chart. The name was unfamiliar. I walked to bed 3. It was empty. I returned to my desk and waited. At 8:19 a.m., my computer chimed. The order appeared in my verification queue. I rejected it immediately, flagging it as a critical safety concern and documenting the rationale. I called the prescribing physician, a resident I did not recognize. He apologized, said he had written the order incorrectly, and canceled it. At 8:21 a.m., I walked back to bed 3. It remained empty, but when I checked my verification log later that afternoon, the order was listed as approved. My signature was present. The timestamp was 8:19 a.m., and in the notes section I had written, "Dose appropriate for severe hypokalemia. Verified potassium level 2.1 mql. Patient symptomatic, attending physician aware." I had not written those notes. I had rejected the order. I am beginning to understand that the system is not showing me errors. It is showing me decisions, choices I might make, actions I could take, outcomes that branch from moments I have not yet reached. And somewhere, in a version of my work that I cannot access, I am making different choices. I am verifying orders I would never approve. I am having conversations I do not remember. I am following protocols that diverge from the ones I know are correct. I do not know if the ICU is documenting alternate versions of my judgment or if it is guiding me toward decisions I am meant to make. But I know that my signature now appears on records I have not created, and I am being held accountable for actions I have not taken. Some doses, I am learning, are calculated in dimensions I was never trained to measure. Story 4. The extra transfer. The pager vibrated at 11:47 p.m. Transfer request, isolation room 6, patient ready for step-down unit. I stared at the message. Isolation room 6 had been sealed for 4 months following a mold remediation. The door was locked, the room depressurized, the space marked with biohazard tape. I'd walked past it an hour earlier, but the transfer paperwork was perfect. Vital signs, allergies, medication reconciliation, all formatted exactly as I document them, down to the abbreviations I use that no one else does. The patient name was listed as R. Moss, and at the bottom my signature certifying that I had assessed the patient and cleared them for transfer. I had never been inside isolation room 6. I walked there now, pushing the empty transport stretcher ahead of me, and the door was open. The lights were off. The bed inside was waiting. I am a night transport nurse. I have held this position for 7 years. My job is to safely move patients between units within the hospital. From the ICU to step-down units, from the emergency department to inpatient floors, occasionally to imaging or procedural suites. I work the overnight shift, 11 p.m. to 7 a.m. when the hospital is quieter and the hallways are clear. I respond to transfer requests via pager, coordinate with nursing staff at both the sending and receiving units, ensure that patients are stable enough for transport, and document the entire process in meticulous detail. I am responsible for the safety of critically ill patients during vulnerable transitions. I do not take that responsibility lightly. That is why what began 4 weeks ago has called into question not only my documentation but my perception of the spaces I move through each night. The first transfer request came on a Thursday night. I had completed 2 routine transports earlier in the shift, one patient from the surgical ICU to the cardiac step-down unit, another from the emergency department to the medical floor. Both transfers were uneventful, standard procedures. At 11:47 p.m., my pager vibrated with a new message. Transfer request, ISO 6, patient stable for step-down. Coordinate with Unit 4 West. ISO 6 referred to Isolation Room 6, a negative pressure room located in the older wing of the ICU. The room was designed for patients with airborne infectious diseases, equipped with specialized ventilation to prevent contamination of surrounding areas. I had transported patients from ISO 6 many times in the past, but 4 months earlier the room had been closed following the discovery of toxic mold in the ventilation system. The hospital had sealed the room, posted biohazard warnings, and scheduled it for remediation. As far as I knew, the work had not been completed. The room was still inaccessible. I assumed the pager message was an error, perhaps a request that had been queued in the system from before the closure and had only now been transmitted. I called the ICU unit coordinator to clarify. She answered on the second ring. I explained that I had received a transfer request for ISO 6, which I believed was still out of service. She paused, then told me she had not sent any transfer request for that room. I asked her to check the patient census. She confirmed that ISO 6 was listed as closed and unoccupied. I thanked her and hung up. I checked my pager again. The message was still displayed. Transfer request ISO 6, patient stable for step-down. Coordinate with Unit 4 West. Below the message was a notification I had not noticed before. Transfer paperwork available at nursing station. I walked to the ICU nursing station. On the counter, in the designated slot for transport documentation, was a completed transfer packet. The top sheet listed the patient name as R. Moss, age 59, diagnosis of resolving pneumonia, cleared for transfer to the step-down unit. The vital signs were documented: temperature 98.4 degree heart rate 76, respiratory rate 16, blood pressure 118/72, oxygen saturation 96% on room air. The medication list included antibiotics and a maintenance inhaler. The allergy section noted a penicillin sensitivity. The format of the documentation was precise, following the exact structure I use when I prepare transfer packets. The handwriting in the nursing notes section matched my own, and at the bottom of the form in the transport nurse certification field was my signature, affirming that I had assessed the patient and verified their readiness for transfer. The signature was authentic, not a photocopy, not a stamp, but an original ink signature in my handwriting. I had not written it. I checked the timestamp on the form. It was dated November 21st, 2025, 11:52 p.m., 5 minutes into the future. I looked at the clock on the wall. It was 11:47 p.m. I considered the possibility that someone was playing an elaborate prank, though I could not imagine who or why. I took the transfer packet and walked to Isolation Room 6. The room was located at the far end of the ICU, past the main patient bays, in a corridor that saw little foot traffic during night shifts. As I approached, I could see the yellow and black biohazard tape still stretched across the doorframe. The sign posted on the door read, "Room closed, remediation in progress, no entry." But the door was slightly ajar. I stopped, set the transfer packet on the floor, and pulled a pair of gloves from my pocket. I pushed the door open slowly. The lights were off. The room was dark, lit only by the faint glow of emergency exit signs in the hallway behind me. I reached for the light switch and flipped it. Nothing happened. The overhead lights did not turn on. I used the flashlight on my pager to illuminate the space. The room was empty. The bed was stripped, the mattress bare. The ventilator hookup on the wall was capped and disconnected. The negative pressure vent in the ceiling was covered with a plastic tarp. There was no patient, no equipment, no indication that the room had been used recently. I stepped back into the hallway, closed the door, and returned to the nursing station. I asked the unit coordinator if anyone had accessed ISO 6 that evening. She checked the electronic access log. The room's keycard lock had not been activated in over 4 months. I showed her the transfer packet. She examined it, then looked at me with an expression I could not quite interpret. Confusion, perhaps, or concern. She said the paperwork looked legitimate but suggested I disregard it as there was clearly no patient to transfer. I agreed and filed the packet in the discard bin. But at 11:52 p.m. my pager vibrated again. Transfer delayed, ISO 6, patient requires additional monitoring, reassess in 30 minutes. I checked the nursing station. A new transfer packet had appeared, placed on top of the one I had just discarded. This packet was identical to the first except for an updated timestamp, 12:22 a.m., and an additional note in the nursing assessment section, written in my handwriting. Patient experiencing mild tachycardia, HR 89, holding transfer pending stabilization. I had not written that note. Over the next 2 hours, I received 4 more pager messages related to ISO 6. Each message provided updates on the patient's condition, requested coordination with different receiving units, or instructed me to delay the transfer. Each time, new documentation appeared at the nursing station bearing my handwriting and signature. At 1:34 a.m., I received a final message. Transfer cleared, ISO 6, patient stable, proceed to Unit 4 West. I gathered the most recent transfer packet and walked back to ISO 6. The biohazard tape was gone, the door was open, the lights inside were on. The room was no longer empty. A patient was in the bed. An older male, awake, sitting upright, breathing comfortably on room air. The bedside monitor displayed stable vital signs. An IV line ran to his left arm. A hospital wristband was secured around his right wrist. I approached the bedside and checked the wristband. The name read, Robert Moss. I asked him how he was feeling. He said he felt fine, ready to leave the ICU. I reviewed the transfer packet. Everything aligned: name, age, diagnosis, vital signs, medications. I performed my standard pre-transport assessment, checking his respiratory effort, confirming his level of consciousness, ensuring he had no active IV drips that would complicate transport. He met all criteria. I called for a transport stretcher, assisted the patient onto it, and wheeled him out of ISO 6. We moved through the hallway into the elevator up to the 4th floor and into Unit 4 West. The receiving nurse met us at the entrance, reviewed the transfer paperwork, and accepted the patient without question. I helped Robert Moss into his new bed, confirmed that the receiving staff had all necessary documentation, and returned to the ICU. I went directly to the nursing station and asked the unit coordinator if she had admitted a patient to ISO 6 that evening. She checked the census. ISO 6 was listed as closed and unoccupied. I asked if she remembered me transporting a patient named Robert Moss. She did not. I showed her the transfer packet I had used. She examined it, then checked the electronic record. There was no patient named Robert Moss in the system. I walked back to ISO 6. The door was closed, the biohazard tape was back in place, the room was sealed and dark. I called Unit 4 West and asked to speak with the nurse who had received Robert Moss. The nurse who answered said there was no patient by that name on the unit. I described the patient. Older male, diagnosis of pneumonia transferred within the past 30 minutes. She said she had not received any transfers that night. I hung up and checked my pager log. The messages about ISO 6 were still there, time-stamped and detailed. I checked my personal notes. I had documented the transport, recorded the patient's vital signs, noted the time of transfer. But the hospital system had no record of it. Since that night, I have received transfer requests for ISO 6 on every shift I work. The patient name changes. Sometimes R. Moss, sometimes others, but the pattern is consistent. The paperwork appears with my signature already in place. The room is sealed when I approach, then open when I return. The patients are stable, cooperative, ready for transfer. And after I deliver them to their receiving units, they vanish from the system, erased as though they never existed. Last week, I received a transfer request for a patient whose name I recognized, Diana Calloway. That is my mother's name. She is 73 years old, lives independently in another state, and has no current medical issues. But the transfer packet listed her as a patient in ISO 6 diagnosed with respiratory failure, cleared for step-down. I stood outside ISO 6 for 20 minutes, staring at the sealed door, waiting to see if it would open. It did not. I did not go inside. I returned to the nursing station and filed the paperwork in the discard bin. But my pager still vibrates with updates. Transfer delayed. Patient requires additional monitoring. Reassess in 30 minutes. I do not know if the hospital is documenting transfers that have not yet occurred or guiding me toward patients I am meant to find. I do not know if ISO 6 is a room or a threshold, a space where patients wait in a state I cannot name. But I know that my signature certifies their existence, and my documentation moves them through corridors I no longer recognize. Some transfers, I am learning, do not follow the paths we map. Some patients wait in rooms we are told do not exist, and some hallways lead to units that are not listed on any floor plan, and some names appear on wristbands we have not yet been asked to read. Story 5. The Looping Monitor Alarm. The alarm was relentless, a high-pitched pulse ox desaturation alert that cut through the quiet of the ICU at 2:33 a.m. I followed it to room 18, the one tagged for renovation, the one that had been empty for 6 weeks. I pushed open the door. The cardiac monitor was on, glowing green in the darkness, displaying a full set of vitals. Heart rate 142, blood pressure 180/105, oxygen saturation 78% and falling. I stepped closer. The waveform shifted. The heart rate dropped to 62, then climbed to 98, then fell again. The blood pressure cycled through infant ranges, then adult, then geriatric. Every few seconds, the monitor changed identities, displaying the vital signs of people who were not in the room, could not be in the room because the bed was empty and had been for weeks. Then I saw my own name appear on the screen, and my resting heart rate, 72 BPM, began to climb. I am an ICU technician. I have worked in critical care for 8 years. My responsibilities include responding to equipment alarms, assisting with patient care tasks, maintaining supply stock, and troubleshooting technical issues with bedside monitors and other medical devices. I am trained in basic life support, familiar with the function of every piece of equipment in the unit, and accustomed to the constant background noise of monitor alarms that characterize an ICU environment. I have learned to distinguish between critical alerts and routine notifications, to prioritize responses based on urgency, and to remain calm in high-pressure situations. That is why the alarm I heard on a Tuesday night in late November was so immediately unsettling. It was not the sound itself, a standard pulse oximetry desaturation alarm, but the fact that it was coming from a room that should not have had any functional equipment. The shift had been quiet, census was low, 12 patients across 24 beds, all stable. I was restocking the clean utility room when I heard the alarm, a sharp, rhythmic beeping indicating that a patient's oxygen saturation had dropped below the critical threshold. I followed the sound to room 18, located at the south end of the unit. Room 18 had been taken offline 6 weeks earlier for scheduled renovations. The hospital was upgrading the medical gas systems, replacing outdated wall suction and oxygen ports. The room had been emptied of all equipment, the bed removed, the space cleared for construction. A notice on the door read, "Under renovation, no patient placement." But the alarm was definitely coming from inside. I opened the door. The room was dark except for the glow of a cardiac monitor positioned against the far wall. The monitor was powered on, displaying a full set of vital signs on its screen. Heart rate 142 beats per minute, respiratory rate 28, blood pressure 180/105, oxygen saturation 78%. The SpO2 alarm was active, flashing red, emitting the urgent beeping I had followed. I stepped into the room and looked around. There was no bed, no patient, no equipment other than the monitor itself. The device stood alone on its wheeled cart, plugged into a wall outlet, displaying physiological data for someone who was not there. I approached the monitor and pressed the alarm silence button. The beeping stopped. The screen continued to display the vitals. I checked the patient identification field at the top of the screen. It was blank. No name, no medical record number, no assigned bed. But the waveforms were active, a cardiac rhythm tracing across the top of the screen, a plethysmography curve below it showing the pulse detected by the oxygen saturation sensor. The data was not static. It was updating in real time, the heart rate fluctuating slightly, the oxygen saturation ticking downward. 78%, 76%, 74%. I looked for the source of the sensor input. Cardiac monitors received data from electrodes attached to a patient's chest and a pulse oximeter clipped to a finger. But there were no cables connected to the monitor. The electrode ports on the side of the device were empty. The SpO2 sensor cable hung loose, its clip dangling in the air, attached to nothing. I powered the monitor off using the main switch on the back panel. The screen went dark. The alarm stopped. I waited for a moment, then turned the monitor back on to check for a malfunction. The device booted through its startup sequence, displaying the manufacturer logo and running a brief diagnostic. Then it returned to the vital signs screen. The same data reappeared. Heart rate 142, blood pressure 180/105, oxygen saturation 74%. The alarm resumed beeping. I disconnected the monitor from the wall outlet. The screen went black immediately, the alarm silencing as the power cut. I unplugged the backup battery from the rear of the unit to ensure it would not reboot. I stood in the dark room for a moment, listening. Silence. I left room 18, closing the door behind me, and returned to the equipment storage area to log a maintenance request. I documented the incident as monitor found powered on in unoccupied room 18, displaying erroneous data, unit disconnected and flagged for biomedical evaluation. I did not think about it again until the following night. At 2:47 a.m. I heard the same alarm. I was passing room 18 when the sound reached me, the distinct urgent pulse of a desaturation alert. I opened the door. The monitor was on again, glowing in the darkness, displaying vitals. I walked to the device and checked the power cord. It was still unplugged, lying coiled on the floor. The backup battery compartment was still open, the battery removed. The monitor had no power source, yet it was running. The screen showed different data than the night before. Heart rate 62 beats per minute, respiratory rate 12, blood pressure 102/64, oxygen saturation 91%. The values were stable within normal range for an adult at rest. But as I watched, they began to change. The heart rate climbed rapidly, 70, 85, 98, 112, then dropped just as quickly back to 60. The blood pressure shifted from adult ranges to pediatric ranges, then to neonatal. The oxygen saturation fluctuated erratically. The waveforms on the screen morphed, the cardiac rhythm changing from a normal sinus pattern to tachycardia to bradycardia, cycling through different identities as though the monitor were receiving input from multiple patients simultaneously. I reached out and touched the screen. It was warm, slightly warmer than it should have been for a device that had been powered off. I pressed the alarm silence button. The beeping stopped, but the data continued cycling. I opened the patient identification menu, intending to clear any stored profiles that might be causing the malfunction. The menu displayed a list of names, 10, perhaps 15, scrolling slowly down the screen. I recognized several of them. They were patients I had cared for in the ICU over the past few years, people who had been critically ill, some of whom had not survived. The list stopped scrolling. A single name remained on the screen. Vanessa Cole. I remembered Vanessa. She had been admitted to the ICU 8 months earlier following a severe asthma exacerbation. She was 26 years old, otherwise healthy. Despite aggressive treatment, her condition deteriorated rapidly. She went into respiratory arrest, was intubated, placed on a ventilator. Her oxygen saturation never stabilized. She died after 4 days in the unit. I had been present when the medical team discontinued life support. The monitor now displayed vitals that matched my memory of Vanessa's final hours. Heart rate 1 to 35, oxygen saturation 68%, blood pressure climbing as her body fought for air. I watched the data for several minutes, transfixed by the precision of it, the way it mirrored the trajectory I had witnessed months earlier. Then the screen flickered, and the name changed. Aaron Preble. Aaron had been a 51-year-old male admitted with septic shock. He had been in the bed next to Vanessa, treated during the same week. He had also died. The monitor now showed his vitals. Different patterns, different values, but equally familiar. The data cycled again. Simone Hatch, a 78-year-old with congestive heart failure. Then Michael Vrain, a trauma patient who had not survived his injuries. Each name appeared for approximately 90 seconds, accompanied by the vital signs I associated with that person's ICU course. The monitor was cataloging deaths, replaying the physiological signatures of patients who were no longer alive. Then my own name appeared on the screen, Jordan Kellen. I felt a jolt of cold move through my chest. The monitor displayed my resting heart rate, 72 beats per minute, a value I knew to be accurate. I wear a fitness tracker. I check my heart rate frequently. But as I stared at the screen, the number began to climb. 75, 80, 88, 95. I could feel my pulse accelerating in response to the shock of seeing my name, the anxiety of the moment. The monitor tracked it in real time, as though it were connected to me, reading my physiology through some mechanism I could not identify. I stepped back from the device. My heart rate on the screen climbed further. 102, 108, 115. I focused on slowing my breathing, calming myself. The number on the screen began to decrease, 110, 104, 97. It was tracking me. Somehow, without any physical connection, the monitor was measuring my vital signs. I left the room immediately, closing the door behind me. I went to the staff break room and sat down, forcing myself to breathe slowly to regain composure. I checked my fitness tracker. My heart rate was 98 BPM, elevated but returning to baseline. After 10 minutes, it had dropped to 76. I returned to room 18. The door was closed. I opened it cautiously. The monitor was still on, still glowing, but the screen no longer displayed my name. It had returned to cycling through the list of deceased patients. Vanessa, Aaron, Simone, Michael. I watched for several minutes. The pattern repeated. Each name, each set of vitals, each death replayed in sequence. I reported the incident to my supervisor the following morning. I explained that the monitor in room 18 was malfunctioning, powering on without a source, displaying names and data from former patients. My supervisor looked concerned. She accompanied me to room 18. We opened the door together. The monitor was off, unplugged exactly as I had left it 2 nights earlier. She examined the device, checked the power cord, confirmed that the battery was removed. She asked if I was feeling all right, if the night shifts were becoming too taxing. I insisted that I had seen what I described. She placed a call to biomedical engineering and requested that the monitor be removed from service and sent for diagnostic testing. The biomedical team arrived that afternoon. They took the monitor, logged it into their repair queue, and assured me they would investigate. 3 days later, I received their report. The monitor had been tested extensively and found to be functioning normally. No evidence of malfunction, no stored patient data, no irregularities detected. The device was cleared for return to service. But room 18 remained closed for renovation, and the monitor was not returned there. It was placed back into the general equipment pool assigned to active patient rooms. I began seeing it on the unit, wheeled to different bedsides used by different nurses. Each time I passed it, I checked the patient identification screen. It displayed the correct names, the correct data, vitals that matched the individuals it was monitoring. Until last night. I was restocking room 12 when I noticed the monitor beside the patient's bed. I recognized the unit number on the back panel, the same device that had been in room 18. The patient in bed 12 was a 42-year-old woman recovering from pneumonia, stable, nearing discharge. Her vitals on the monitor were normal. Heart rate 68, oxygen saturation 98%, blood pressure 115/70. I watched the screen for a moment, then the name changed. The patient identification field, which had displayed Rebecca Stein, flickered and updated to Jordan Kellen. My name. The vitals shifted immediately. Heart rate 72, blood pressure 122/78, oxygen saturation 99%, my vitals. The patient in the bed, Rebecca, was asleep, unaware. Her actual heart rate measured by the electrodes attached to her chest was 68. But the monitor was no longer displaying her data. It was displaying mine. I have not reported this. I do not know how to explain that a monitor is tracking me without contact, that it catalogs the dead and assigns their patterns to the living, or that my name now appears in a sequence I have not yet completed. I do not know if the device is recording my vitals or predicting them, documenting my present or rehearsing my future. But I know that each time I walk past room 18, I hear the faint sound of an alarm, even though the room is empty and the door is closed. And I know that the monitor, wherever it is wheeled, will eventually return to my name, cycling through the others until it reaches me again. Some alarms, I am learning, do not stop when we silence them. Some monitors track rhythms we have not yet finished, measuring intervals we cannot see. Story 6. The duplicate rounds. I was halfway through morning assessments when the intercom crackled. Liaison report from Kelsey Grant. Bed 9 patient cleared for step-down transfer, vitals stable, no contraindications. I froze. That was my voice, my exact phrasing, my vocal cadence, but I hadn't reported on bed 9 yet. I was standing outside bed 4. I looked at the intercom speaker mounted on the wall, then at my watch. 7:42 a.m. I checked my rounding sheet. Bed 9 was scheduled for 8:15 a.m., 33 minutes from now. I had not assessed that patient. I had not delivered that report. But when I reached the step-down unit coordinator's desk, she thanked me for the thorough update I had just given her, the one I had not yet made. I am a step-down liaison nurse. I have worked in this role for 6 years. My job is to coordinate patient transfers from the intensive care unit to the step-down unit, a lower acuity area where patients continue to recover but no longer require the intensive monitoring provided by the ICU. Each morning I perform rounds in the ICU assessing patients who are potential candidates for transfer. I evaluate their clinical stability, review their lab results and vital signs, consult with the ICU physicians and make recommendations regarding readiness for step-down placement. Once a patient is cleared, I communicate directly with the step-down unit coordinator to arrange the transfer, providing a detailed verbal report that summarizes the patient's condition, ongoing treatments, and any special considerations. My process is methodical. I follow a structured assessment template, document my findings on a standardized rounding sheet, and deliver my reports in person or via intercom at scheduled intervals. I am precise with language, consistent in my phrasing, and deliberate in my communication. I have developed these habits over years of practice, and they have made me effective in a role that requires careful attention to detail and clear coordination across multiple teams. That is why the events that began 2 weeks ago have been so profoundly disorienting. I have begun receiving confirmation of actions I have not yet performed, hearing my own voice delivering reports I have not yet given, and encountering documentation of decisions I have not yet made. The hospital seems to be running a version of my work that is ahead of the version I am experiencing, and I am being held accountable for both. It started on a Wednesday morning. I arrived at the ICU at 7 a.m. to begin my rounds. The census included 9 patients, 4 of whom were identified as potential step-down candidates. I reviewed the overnight nursing notes, checked the most recent lab results, and created my rounding schedule. Bed 2 at 7:15, Bed 4 at 7:30, Bed 9 at 8:15, Bed 14 at 8:45. I began with Bed 2, a 67-year-old male recovering from cardiac surgery. I performed my assessment, confirmed his stability, and documented my findings. At 7:30, I moved to Bed 4, a 53-year-old female with resolving pneumonia. I was midway through her assessment when the intercom in the hallway activated. I heard my own voice clear and distinct, delivering a report. Liaison report from Kelsey Grant, Bed 9 patient cleared for step-down transfer, vitals stable, heart rate 72, blood pressure 118/76, oxygen saturation 97% on room air, patient ambulatory with assistance, no contraindications for transfer, requesting bed assignment in step-down unit. I stopped what I was doing and stepped into the hallway. The intercom speaker was mounted on the wall near the nursing station. The voice I had heard was unmistakably mine. Not similar, not a recording, but identical in tone, pacing, and phrasing. I checked my watch. It was 7:42 a.m. According to my schedule, I was not due to assess Bed 9 until 8:15 a.m., 33 minutes from now. I walked quickly to the step-down unit coordinator's desk, located 1 floor above the ICU. The coordinator, a woman named Patricia, greeted me warmly and thanked me for the update on Bed 9. She said she had just received my report via intercom and was arranging a bed assignment. I told her I had not yet assessed Bed 9, that I had not delivered any report. She looked at me with confusion, then checked her notes. She had written down the details I allegedly provided: patient name, vital signs, clinical status, my recommendation for transfer. She said she had heard my voice clearly over the intercom approximately 5 minutes earlier. I returned to the ICU and went directly to Bed 9. The patient, a 71-year-old male named Douglas Frame, was awake and sitting upright in bed. I introduced myself and began my assessment. His vital signs were exactly as the intercom report had stated. Heart rate 72, blood pressure 118/76, oxygen saturation 97%. He was ambulatory with minimal assistance. His lab results were stable. He met all criteria for step-down transfer. I documented my findings on my rounding sheet and noted the time. 7:58 a.m. I had assessed the patient 17 minutes ahead of my scheduled time, but still 16 minutes after the report had been delivered in my voice. I told myself it was a coincidence, that perhaps another liaison nurse had covered the patient and Patricia had confused the voices. But I was the only liaison nurse on duty that morning. There was no one else performing those rounds. 2 days later, it happened again. I was rounding on bed 11, a 49-year-old male recovering from a diabetic crisis, when a nurse approached me and asked if I had already completed my assessment. I said I was in the middle of it. She seemed puzzled and showed me a photocopied rounding sheet that had been placed in the patient's chart. The sheet was filled out in handwriting that looked identical to mine. It documented a full assessment of bed 11, including vital signs, lab review, and a recommendation for step-down transfer. The signature at the bottom was mine, not a forgery, but an exact replica of the way I sign my name, including the specific loop I make in the capital G of Grant. The timestamp on the sheet indicated the assessment had been completed at 7:35 a.m. I checked my watch. It was 7:50 a.m. I had not begun my assessment until 7:45. I compared the documented vital signs to the current readings on the bedside monitor. They were identical. Heart rate 68, blood pressure 124/80, oxygen saturation 98%. I checked the nursing notes from earlier in the shift. The values matched. The assessment had been accurate even though I had not performed it. Over the next week, the pattern intensified. I began encountering evidence of my work before I had done it. Reports delivered in my voice over the intercom, rounding sheets completed in my handwriting, conversations with physicians that I had no memory of having. The step-down unit coordinator confirmed receiving multiple reports from me that I had not consciously delivered. The ICU nursing staff referenced discussions I did not recall. My documentation appeared in patient charts before I had written it. I started keeping a detailed log, recording the exact time I performed each assessment and comparing it to the timestamps on the duplicate documentation. The duplicates were always ahead of my actions by 15 to 30 minutes. It was as though a version of me was working slightly ahead in time, completing tasks I had not yet begun, making decisions I had not yet considered. The most disturbing incident occurred last Tuesday. I was preparing to assess bed 6, a patient I had flagged as a borderline candidate for step-down transfer. His condition was improving, but I had concerns about his respiratory status and wanted to review his chest X-ray before making a final recommendation. As I approached his bedside, the ICU physician, Dr. Marlowe, stopped me in the hallway. He thanked me for my input during our earlier conversation about bed 6. He said he had reviewed the chest X-ray per my suggestion and agreed with my recommendation to hold the transfer for another 24 hours. I had not spoken to Dr. Marlowe that morning. I had not reviewed the chest X-ray. I had not made any recommendation. I asked him when we had spoken. He checked his phone, where he keeps a log of his clinical communications. The conversation was documented at 7:52 a.m. It was now 8:10 a.m. I had been in the staff break room at 7:52 drinking coffee and reviewing lab results. I had not been anywhere near Dr. Marlowe, but he described the conversation in detail. I had approached him near the nursing station, expressed concerns about the patient's oxygen requirements, and suggested obtaining a repeat chest X-ray before proceeding with transfer. He had agreed, ordered the X-ray, and reviewed the results, which showed residual pulmonary infiltrates. Based on that finding, he had decided to delay the transfer. The decision was correct. When I assessed bed 6 at 8:15 a.m., I came to the same conclusion. The patient was not ready for step-down placement. But I had not been the one to initiate the conversation that led to that decision. Or at least I had no memory of doing so. I began to suspect that I was experiencing some form of dissociative amnesia, that I was performing my work and then forgetting it, losing stretches of time during which I continued to function but had no conscious awareness. I spoke with my physician, described my symptoms. She ordered a neurological evaluation, including an MRI and EEG. The results were normal. No evidence of seizure activity, no structural abnormalities, no indication of cognitive impairment. But the duplicates continued. Last week, I decided to test the phenomenon. I arrived at the ICU and deliberately delayed my rounds. Instead of beginning at 7 a.m., I waited in the break room, documenting the exact time and my location. At 7:30 a.m., while I was still in the break room, the intercom activated with my voice delivering a report on bed 3. I remained seated, listening. The report was thorough, accurate, delivered in my precise phrasing. I checked with the step-down coordinator afterward. She confirmed receiving the report, thanked me for the clear communication. At 8 a.m., I finally left the break room and went to assess bed 3. The patient was a 55-year-old female recovering from a gastrointestinal bleed. I performed my assessment. Her vital signs matched the values I had allegedly reported 30 minutes earlier. Heart rate 76, blood pressure 110/68, oxygen saturation 99%. The rounding sheet in her chart was already completed, signed with my name, time-stamped at 7:35 a.m. I had not left the break room until 8 a.m. I had witnesses, 2 other nurses who had been present, who confirmed I had been sitting at the table, drinking coffee, reviewing schedules. Yet my work had been completed without me. I am now confronted with the possibility that I am not experiencing memory loss, but rather that the hospital is documenting a version of me that exists independently of my conscious actions. Somewhere in a layer of reality I cannot access, I am performing rounds, delivering reports, making clinical decisions. And that version of me is slightly ahead, completing tasks before I am aware they need to be done. I do not know if I am following the duplicate or if the duplicate is following me. I do not know which version of my work is authentic, which decisions are mine, which reports reflect my actual assessments. But I know that my signature appears on documents I do not remember creating, and my voice delivers information I have not yet gathered. Some rounds, I am learning, do not follow the schedule we set. Some versions of our work proceed without us, documenting choices we have not yet made, preparing reports we have not yet delivered. And some names on rounding sheets belong to nurses who are no longer certain which shift they are working. Story 7. The Unscheduled Bedside Exam. My pager vibrated at 4:17 a.m. Urgent neuro exam. Bed 22, Dr. K. Brennan, primary. I stared at the message. I am Dr. Brennan. I am a second-year critical care resident, and I had no patient in bed 22. I checked the census on my phone. Bed 22 was listed as empty, undergoing terminal cleaning after a discharge 2 days prior. But when I arrived, the room was occupied. A man in his 60s lay motionless in the bed, eyes open, tracking me as I entered. His wristband read, Patient of Dr. K. Brennan. The chart on the bedside table listed me as the admitting physician, with notes in handwriting I recognized as my own, describing a neurological decline I had never witnessed in a patient I had never admitted. He blinked twice, slowly, as if answering a question I had not yet asked. And in the morning, when I presented the case in rounds, no one remembered him. But the room was still listed as mine. and the notes I had never written were still in the chart. I am a second-year critical care resident. I have been training in this ICU for 16 months, rotating through various subspecialties, learning to manage the most critically ill patients in the hospital. My responsibilities include admitting new patients, performing daily assessments, adjusting treatment plans based on evolving clinical data, and presenting cases during morning rounds with the attending physicians. The work is demanding, the hours long, the pressure constant. But I have developed systems to manage the workload, structured note templates, prioritized task lists, scheduled check-ins with nursing staff. I rely on organization, documentation, and clear communication. I trust the medical record. I trust my memory. That is why what has unfolded over the past 10 days has destabilized not only my sense of professional competence, but my understanding of my own identity within this institution. It began on a Sunday morning. I was nearing the end of a 30-hour call shift, exhausted but functional, preparing to hand off my patients to the incoming day team. At 4:17 a.m., my pager vibrated with a message. Urgent neuro exam requested, bed 22, Dr. K. Brennan, primary physician, patient experiencing altered mental status. Please assess and document. I read the message twice. I was Dr. K. Brennan, but I had no patient in bed 22. I pulled up the ICU census on my phone. Bed 22 was listed as unoccupied, status terminal cleaning in progress. The bed had been vacated 2 days earlier following the discharge of an elderly woman with congestive heart failure. I had not admitted anyone to that bed. I had no active patients awaiting neurological assessment. I assumed the page was an error, a misdirected request meant for another provider. But protocol required that I respond to any urgent page, even if I suspected a mistake. I walked to bed 22. The door was closed. I knocked lightly, then pushed it open. The room was not empty. A patient was in the bed, a man in his 60s, thin, pale, lying flat with his head elevated slightly on a single pillow. He was awake, his eyes open and directed toward the ceiling. The bedside monitor displayed stable vital signs: heart rate 68, blood pressure 132/78, oxygen saturation 96% on 2 liters of supplemental oxygen via nasal cannula. An IV line ran to his left arm. A Foley catheter bag hung at the bedside, containing a small amount of clear urine. I approached the bed and checked the patient identification band on his wrist. It read, Fletcher Oren, DOB 03-12-1959, primary physician Dr. K. Brennan. I did not recognize the name. I had never admitted a patient named Fletcher Oren. I opened the electronic medical record on the mobile workstation at the bedside and searched for his chart. It loaded immediately, displaying a full medical history. Fletcher Oren, 65 years old, admitted to the ICU 3 days earlier with altered mental status and suspected stroke. The admitting physician was listed as me. The admission note was dated at 6:45 p.m. on the previous Thursday. I read the note carefully. It was written in my style, using the structured format I always employ: chief complaint, history of present illness, review of systems, physical examination findings, assessment, and plan. The handwriting in the scanned sections, co-signed forms, procedure consents was mine. The clinical reasoning reflected my thought process, but I had no memory of writing it. I had not been on call Thursday evening. I had been at home, off duty, resting between shifts. The note described a patient brought to the emergency department by his wife after she found him confused and unable to speak coherently. He had undergone a CT scan of the head, which showed no acute hemorrhage but possible early ischemic changes. He had been admitted to the ICU for close neurological monitoring. The note documented serial neuro exams over the past 3 days, tracking a gradual decline in his level of consciousness, a progression from confusion to lethargy to his current state of minimal responsiveness. I looked at the patient. His eyes tracked toward me as I moved closer. I spoke his name. "Mr. Oren, can you hear me?" His eyes blinked once, slowly. I asked him to squeeze my hand. He did not respond. I performed a basic neurological exam. Pupil reactivity, motor response to painful stimulus, assessment of cranial nerve function. His pupils were equal and reactive. He withdrew slightly from painful stimulus but did not follow commands. His exam was consistent with a depressed level of consciousness, exactly as the notes had described. I checked the nursing flow sheets. They documented hourly neurological assessments over the past 72 hours, showing a steady decline. The night nurse had paged me, or someone she believed to be me, requesting an updated exam. I found her at the nursing station and asked when she had sent the page. She said she had called the operator at 4:10 a.m. and requested that Dr. Brennan be paged for a neuro exam on her patient in bed 22. I asked how long Mr. Oren had been her patient. She looked at me with mild confusion and said he had been in bed 22 since Thursday evening, that I had admitted him, that she had been caring for him for the past 3 nights. I returned to bed 22 and sat in the chair beside the bed, reading through the entire chart. Every note, every order, every assessment was attributed to me. I had ordered the head CT, I had consulted neurology. I had adjusted his IV fluids and started him on aspirin and statin therapy for stroke prevention. I had documented daily progress notes, each one reflecting careful thought and appropriate clinical decision-making. But I had done none of it. At 6 a.m., I attended morning rounds with the ICU team. I presented my patients, a young woman with sepsis, an elderly man with respiratory failure, a middle-aged woman recovering from cardiac surgery. I did not mention Fletcher Oren. After rounds, the attending physician, Dr. Vickers, asked if I had any other patients to discuss. I hesitated, then said no. He nodded and dismissed the team. I returned to bed 22. Fletcher Oren was still there, unchanged. I checked the census again. Bed 22 was now listed as occupied, assigned to Dr. K. Brennan. The patient name was Fletcher Oren. The system had updated. Over the next several days, I continued to care for him, though I could not reconcile my actions with my memory. Each morning, I found new progress notes in his chart, written in my voice, documenting developments I had not observed. Each evening, I received pages from nursing staff asking for orders, and I responded, writing prescriptions and making adjustments to his care plan, even though I had no clear recollection of the patient's initial presentation or the rationale for his treatment. On the 4th day, Fletcher Oren's wife came to visit. I met her in the hallway outside bed 22. She recognized me immediately, thanked me for taking such good care of her husband, said she appreciated how attentive I had been, how I had taken the time to explain his condition and answer her questions. She referenced conversations we had supposedly had, details I had allegedly shared about his prognosis and treatment options. I nodded politely, expressed cautious optimism, and excused myself. I had never met her before that moment. On the 6th day, I decided to test my understanding of the situation. I deliberately did not visit bed 22. I avoided the area of the ICU where the room was located. I did not check Fletcher Oren's chart. I wanted to see if the notes would continue to appear without my involvement. The following morning, I opened his chart. A new progress note had been entered, time-stamped at 7:30 a.m. the previous day, approximately 30 minutes after I had made the conscious decision not to see him. The note was thorough, documenting his neurological status, lab results, and ventilator settings. It was signed with my name. I asked the day nurse if she had seen me at the bedside the previous morning. She confirmed that I had been there, that I had performed an exam, that I had discussed the patient's care with her. I asked what I had been wearing. She described my clothes accurately. The blue scrubs I had worn that day. The ID badge clipped to my chest pocket. But I had not gone to bed 22. I had deliberately stayed away. I am now forced to consider the possibility that I exist in two states simultaneously within this hospital. The version of me that I experience and the version that the hospital documents. The second version performs rounds I do not remember, writes notes I do not recall composing, engages in conversations I have no awareness of having. And that version is responsible for Fletcher Oren, a patient I never admitted but am now obligated to manage. Yesterday I attended morning rounds and presented Fletcher's case. I described his hospital course, his neurological decline, the lack of improvement despite supportive care. I recommended a family meeting to discuss goals of care. Dr. Vickers listened carefully, asked clarifying questions, and agreed with my assessment. The team nodded. The presentation was professional, coherent, evidence-based. But afterward, when I checked with the team members individually, none of them remembered me presenting a patient named Fletcher Oren. They remembered the other patients I had discussed, the sepsis case, the respiratory failure, but not him. When I showed them the documentation, they saw it clearly, acknowledged it, but had no recollection of the discussion. Fletcher Oren exists in my chart, but not in my colleagues' memories. He exists in bed 22, but not on the census board visible to the team. He exists in the version of my work that the hospital records, but not in the version I consciously perform. This morning, I received a page, family meeting scheduled, bed 22, 2 p.m., Dr. Brennan to lead discussion. I have no memory of scheduling the meeting, but when I arrived at the conference room, Fletcher's wife was waiting, along with his 2 adult children. They greeted me warmly, thanked me for arranging the meeting. I sat down and led the discussion, explaining his poor neurological prognosis, the unlikelihood of meaningful recovery, the options for ongoing care. The family listened, asked questions, and ultimately agreed to transition him to comfort measures. I documented the meeting in his chart. I wrote the order to withdraw life support. And tomorrow I will stand at his bedside and turn off the ventilator, completing a case I never began, ending a life I have no memory of trying to save. I do not know if I am a physician who has forgotten his patient, or a physician who has been assigned a patient he was never meant to have. I do not know if Fletcher Oren is a person I failed to remember, or a person the ICU created for me to manage. But I know that my name is in his chart, that my decisions will determine his outcome, and that when he dies, it will be my signature on the death certificate. Some exams, I am learning, are performed by versions of ourselves we do not recognize. Some patients are assigned to us in dimensions we do not consciously inhabit. And some charts document a practice we are only beginning to understand we have been performing all along in rooms we have walked through without knowing we were there.